Welcome to It's Beyond the Food podcast. I'm your host, Stephanie Dodier, non-diet nutritionist and founder of the Non-Diet Coaching Certification. This is Beyond GLP-1, the Expert Series. I created this series of podcast episodes because informed consent required the full picture, not just the press release. So over the next several episodes, I'm bringing in experts to cover every angle: science, marketing, side effect, impact on body image, nutrition, health, counseling, and what all this means for you and your client. Whatever you are, a health professional navigating these conversations in your practice or someone personally researching your decision, this series is for you. Ready? Let's do this. Welcome to the podcast, Michelle.
Thank you so much. Super excited to be here with you, Stephanie.
I'm excited to have you and your expertise as a medical practitioner. But let me ask you first, introduce yourself so everybody know who you are and your expertise, and then we'll get going on the conversation.
Sure. So I'm Dr. Michelle Tubman. I am an emergency medicine physician over in Edmonton, Alberta in Canada. And I have a particular interest in weight-inclusive medicine because of the struggles I have had being not just a fat woman, but also a fat doctor. In this profession, it's not easy to navigate. And through my own personal struggles, I also did additional training in coaching, intuitive eating, body trust work to try and help me heal the relationship I had with my own body, and by extension, help other women in particular heal their relationship with theirs. And that training that I took and the work that I've subsequently done as a coach has really informed how I practice medicine. And I have really come to be very passionate about teaching other physicians and modeling for other physicians what it means to be a weight neutral or a weight inclusive physician.
We need more of you.
Yes, we do.
Okay, we're going to start with the basic and then get into the deeper stuff. Does that
Sounds
make sense?
good. Yeah.
So we're on this series talking about GLP-1. So just so we go through the basic, what's a GLP-1 and what does it do for the body, or what is it observed clinically to do for the body? Can you take us through the basic?
Sure. So basically, GLP-1 medications are a group of medications that were actually developed a long time ago for the treatment of type 2 diabetes. What had happened is during studies examining this particular use, they noticed that weight loss was a side effect of this drug. Taking advantage of that fact, they decided to study this drug at higher doses to maximize this side effect of weight loss, to see if it would actually result in weight loss, taking this medication at the higher dose for that purpose. And so now we have this duality, this two purpose for this drug. One is the very legitimate treatment of type 2 diabetes, but also, as we're all very well aware now, it seems to be the primary use now is for weight loss. And we see it everywhere. I was watching the Montreal Canadiens play a couple nights ago, and even in the NHL playoffs, we've got Ozempic advertisements on the boards on the rink. So that messaging is really, really everywhere. But the original purpose of these drugs was to treat type 2 diabetes. And it does this through many different mechanisms in terms of glucose metabolism, but it also affects multiple different systems in the body, including in our brain and nervous system and in our digestive system, as well as in our metabolic system.
And this is why we see kind of two group of people taking GLP now, be it when 2026, the biggest group is people taking it for intentional weight loss. But we have a smaller group that were taking and probably still taking GLP-1 long term as any other medication like metformin. It's just a medication. Is that correct?
That is correct. And what we're also seeing now is people looking at additional uses for GLP-1s, like treating Alzheimer's has come up recently, and kidney disease and other conditions as well.
Okay. So from a practical standpoint, this is a question that I've had because I'm not a prescriber, like I'm not someone who can prescribe, but my understanding is when you do we'll take type 2 diabetes medication for that particular condition, which is one of the most prominent medical condition. If we were to take GLP-1 for type 2 diabetes versus intentional weight loss, the dosage would be different. Is that accurate?
Yes, that is correct. So the dosage for type 2 diabetes is much lower than what people are prescribing for weight loss.
So to achieve the weight loss, that's why in the beginning they were seeing benefit without necessarily losing weight, because at a lower dose, it effectively reduced symptoms of type 2 diabetes without inducing weight loss.
Well, it's even at the type 2 diabetes doses, some people do still experience weight loss. The thinking was, since we do see weight loss as a side effect at this lower dose, if we make the dose higher, people will lose more weight. And of course, the higher the doses, the more money the pharmaceutical companies make as well.
For sure, because they sell more of the set product that makes them the money. Mm-hmm. So is it also true to say that the symptoms that people are talking about, right, that we talk about digestive issue, that we talk about constipation, even the loss of desire, these symptoms primarily started to be observed or are observed in higher dose that is used for intentional weight loss, and not necessarily at the lower dose for medical purposes?
Correct. So people still can experience these side effects at the lower dose as well. But if we increase the dose, of course, we experience more of the side effects as well.
And so that is why we're talking more and more, or hearing more and more, people not being able to stay on the GLP medication long term, which is what needs to happen in order to maintain the weight loss benefit because of the symptoms that people are experiencing.
Yeah, so a few things to actually say there is, first, as an emergency doctor, I don't actually prescribe GLP-1s. It's not within my wheelhouse, but I certainly see patients on every shift who come to the emergency department with side effects from them. It's a common thing for me to see in my practice. But the other thing that's important to say here is it's not necessarily just side effects that cause people to stop taking this medication. So you also mentioned in there that you need to stay on it to maintain weight loss over time. The studies are actually quite convincing that even if you stay on these medications long term, the weight does eventually start to creep back on. And this is due to very physiological reasons called metabolic adaptation, is that your body systems actually start to adapt to the lower calorie intake that you're taking in with these medications. Your metabolism lowers and weight starts to come up regardless of whether you're still on this medication or not. But what I find very interesting is one of the original studies that they did on semaglutide, which is also known as Ozempic. They followed people for a number of years. And what's interesting is 90%, well, almost 89% of the people in that study dropped out before the end of the study. And the authors, of course, were from the pharmaceutical industry and did not tell us in this paper why these people dropped out. But we can assume it's one of two things. One, of course, is the side effects were unmanageable or unacceptable for people. But the second is that it just wasn't working. So either they didn't lose weight to begin with, or they lost weight. And by the time that, about 2-year mark comes on, the weight starts coming back on again. And so in studies, people are provided these medications. In real life, people also have to pay for them. And so the financial piece might also be a part of the picture as well.
What's interesting is the word you use. People left or stopped taking the drug, left the study because they weren't working, quote unquote working, meaning they weren't working for the purpose that they were taking it, which was purely intentional weight loss.
Correct. And so this is just unheard of in scientific
Yes.
studies to have a dropout rate that high. But they would go on and, talk about the dramatic weight loss they see. But that was only in 10% of the people who actually started taking the medication. It's an important piece of information that's not often talked about when we talk about the evidence around these medications.
So I want to come back on this piece, being that you are an emergency care physician. I never heard anyone say this before, that you're starting to see almost at every shift patient coming in emergency care for symptoms that are due to GLP-1.
Correct.
Can you give us some example?
For sure. And I would say I'm seeing a little bit less now than I was a year or two ago. But I'm still seeing it. For sure, the most common that I see in the emergency department is vomiting.
Really?
Absolutely. Abdominal pain and vomiting is the number one cause. People come in because those symptoms are severe enough that they're just unable to keep anything down. But I have also seen gallbladder issues. I have also seen ileus, which is when the bowels really stop moving in the belly. And I have seen a couple cases of suicidal ideation that started after being on Ozempic for a little while as well.
And that's going to lead me into the next part of this interview, which is, in the prescription world, we have something called informed consent, right?
Correct. Yes.
So when those folks comes into an emergency room with symptoms, do they have an idea that it's due to their GLP-1 medication, or they just are not connecting the two? And that's probably due to informed consent or not being informed in the side effects.
So when it comes to the issue of informed consent, it's complicated when it comes to the GLP-1s. And I say that because we have this whole cultural piece where the predominant narrative in this culture we live in is that being fat is bad, being fat is dangerous, being fat is going to kill you. So we have to do everything we can to help you lose weight. And many people out there in the world do not question this. They just believe it's true and listen to that. And of course, those of us who live in bigger bodies and have to navigate through this world of fat phobia, of course, we want to lose weight as well. But when we go and see a physician who also trained in that paradigm, they don't necessarily understand the broader implications of prescribing these medications because they just don't think about it. And so one of the issues that almost no one talks about when we prescribe this medication is actually talking to patients about their relationship with food and if they have a disordered eating history. Because one thing we know for certain is that taking these medications tends to make disordered eating worse if you already have disordered eating, or may even start disordered eating because of how the medication works. And so if you are, for example, using food as a primary mechanism to cope with challenges in life or with difficult emotions, and you take a medication that takes your ability to use food in that way away from you, then you're left with no real skills to help navigate these situations in life that you always use food to help you do. And we're not always consciously aware that our relationship with food functions in this way because we've done it so long and we do it without thinking. It all becomes habitual. And so that often is what leads to the mental health conditions that we sometimes see emerging in people taking these medications. And so this is an example of one of the things we're not talking about with patients before we prescribe this medication. And the other thing that we often don't talk about is that 90% dropout statistic, right? In that there is a very good chance if you start this medication, you will lose weight, but there's an equally good chance that you will gain it back over time. And the other thing that many doctors do not understand is how dangerous this weight cycling, or what we call yo-yo dieting, can be to our health. So a lot of the medical conditions that we associate with being a risk of being overweight is also a risk of this weight cycling. And so if we're going to give patients a medication that's going to help them lose weight, but then ultimately gain it back after a few years' time, we're contributing to harm by putting them into this yo-yo dieting cycle. And then another thing that I think is important, and I think people do talk about this a little bit, but whenever we lose weight intentionally, whether it's through diets or a medication, we lose more muscle mass than we do fat tissue in the body. And when we start to regain the weight back afterwards, we don't necessarily gain the muscle mass back. We gain a lot of that weight back in the form of fat tissue. And that can contribute to worsening health outcomes as well. And so there's a lot of harm that we do in the long term prescribing these medications. And one thing I do base my medical practice on is, another important piece called autonomy, in which, people get to make their own decisions about what they want for their body, but that those decisions need to be made after true informed consent is given, which means people need to be told all of these potential issues with these drugs before they can actually make an informed choice for themselves.
So in the prescription process, as a prescriber, what you're saying is it's not mandatory to screen people for eating disorder, for an example,
correct, prior
to prescription. Currently, the process does not require that.
Correct.
That's insane.
Well, it's look at it this way.
I get disordered eating because that's not screenable as effectively as an eating disorder, but
sure. But if you think about other things, like for example, let's say you're diagnosed with cancer, like God forbid, and you sit down with an oncologist who tells you all the different treatment options, and chemotherapy is one of them, and they tell you about all the potential side effects. And they also tell you, here is the likelihood of this cancer or this, chemotherapy treating your cancer effectively, right? And then you get to take all of that information together and decide what's best for you and your body and what's in line with your values, right? But when we prescribe GLP-1s, we're not having these conversations. We're saying, congratulations, I support your intentional weight loss efforts. Here's your prescription, right?
And so as a prescriber yourself, why do you think the same informed consent is not taught and practiced as it is with chemotherapy, for an example?
I think it's the same as what I mentioned at the start of this conversation, that we're just swimming in this water that tells all of us, providers and patients alike, that fat is bad.
Talking about internalized fat phobia, both on the practitioner, provider, and the patient as well.
Exactly, right? Like, I don't blame anybody for going to their doctor asking for this medication, because the truth of the matter is it would be easier to, navigate through this world in a smaller body. And also, we believe that our health will be better if we lose weight, we'll live longer if we lose weight, etc. The science actually does not support any of that, but we believe all of that. And the other thing that we internalize if we happen to live in a bigger body is all of these messages that we've heard since our childhood that tells us that we are not good enough unless we're thin. And if we're not thin, then we at least better be doing something to get ourselves thin. And then we're deemed worthy in our cultural environment.
So if we come back to the start where we were talking about incidents presenting in emergency care of people with side effects, understanding now the landscape of people not being informed when they're saying yes to the prescription, then it's no surprise that people will come to emergency care with said symptoms and not associating it with their use of GLP-1.
Yep. So when it comes to nausea and vomiting, I'd say people often do associate that with the medications. But when it comes to the mental health stuff, that's the first time they've heard it. Yeah.
Wow. Okay, so and if I can come back on the conversation about inflammation, because I saw a study this week that came out on cardiovascular benefits of GLP-1 independent of weight. And now it's to me mind blowing that they would put the research out demonstrating that the benefits were seen independent of weight loss. And the theory behind that is inflammation pathways
Sure.
being positively impacted by GLP-1. And then the reporter in the article was saying, as far as like, this is so revolutionary that we should potentially in the future, quote unquote, put it in the water and put everyone on GLP-1
Yeah.
because of the benefit of inflammation. And to me, like, we're now going in a very dangerous path. It was already dangerous, but this is
Yeah.
like extreme.
And it's more dangerous than you even think, because the media will often misrepresent the data because they don't understand the statistical properties that the study is actually commenting on. And so they'll make it sound very, very dramatic when really it actually isn't. And so this is not the first study of its kind that's been done. And I haven't read the study that you're talking about specifically, but certainly in ones that have been done recently, yes, some of these studies are showing improvement in terms of cardiovascular benefit, but no more so than the other medications we already use for these purposes.
Ah,
And so when you're reading articles in the media, you got to ask yourself, like, first of all, what doses are they using? Because if they're using the diabetes dose, that sends a very different message than if they're testing the weight loss
high
dose for these
doses.
things, right? And you also want to look at the role of weight loss, because so in this particular study, it said independent of weight loss. Other studies will say it's because of the weight loss. So you got to pay attention to that. You'll also want to look at who are the researchers, who is funding the study, because the vast majority of them are coming from the pharmaceutical industry, and they will design their studies to send out this specific message. And then you also need to look again at what are the other medications or lifestyle interventions we are using to improve cardiovascular health or whatever condition you're studying, and are the GLP-1s actually doing any better than what we've already got, given all of the side effects, like the harmful effects of these GLP-1s that we know are present.
So if we're back to informed consent again, are the prescriber understanding of all these variation and the result of the research to be able to effectively give an informed consent to a patient?
No.
This,
No.
yeah.
No. And oftentimes they're just reading the media, right?
headline.
The same way you are reading the headlines. But trust me, there's not a doctor out there who has the time to keep up with all of the studies that are published every week. And so, people who are actively working in this particular field will have their finger on the pulse of the research much more than like the average family practitioner out there would, for sure.
Yeah, the family physician that we go see all the
Exactly.
time to get counsel on those particular medications. Is there a difference? I know we're both Canadians, so for people listening to that, at the beginning she mentioned the hockey game and having the medication in the hockey rink. That's abnormal for us as Canadian to have medication or pharmaceutical advertisement out in the world. It's very different than the United States. Do you see a difference in the usage, prescription, the environment of GLP-1 in Canada versus what your colleague in the States are living through and people are living through?
I can't comment on what they're living through in the US, but I know when I don't watch a lot of TV, but I do watch my hockey, and it's every game. Talk to your doctor about Ozempic. Like it's It's remarkable how much the advertising of these medications have infiltrated everyday life.
Yeah, and we did an interview for people listening to the podcast with Louise Adam, who published a paper on that, so I won't extend myself on that. In Canadian medicine, are we prescribing GLP-1 as, I want to be careful using the word loosely, as what perhaps is being seen in the United States, or there's more rigorous guidelines around it?
I don't think there are more rigorous guidelines around prescribing it in either country. I think the difference is who gets coverage. I think that probably differs from country to country, but the prescribing practices and the motivations behind prescribing them, I think, are probably the same across the border.
Okay, so given that we live in Canada under a national healthcare system, which most people are used to their medication being covered, what does it look like from a prescription perspective in a practice? Do people prescribe it for intentional weight loss in Canada?
Oh my gosh, of course, yes. Oh yes.
There's no guideline around that more than the United States.
So there are guidelines from, Obesity Canada, and there are like pediatric guidelines in Canada, but they're very much mirroring the guidelines that we're hearing elsewhere.
Oh, my understanding was that, particularly in Quebec, where I'm from, that the prescription of GLP-1 globally could not just be for pure intentional weight loss. There needed to be a case of what they call pre-obesity, like an attached chronic condition to it.
Yes. So when these guidelines will say that they are indicated for treatment if you have a certain BMI and if you have one or more associated conditions with it, right? But that doesn't mean that's the only time you can prescribe these medications, right? And so people are prescribing it for people who do not necessarily meet that definition, for
These
sure.
guidelines.
I'm seeing it all the time. Absolutely.
Yeah, for just what I call aesthetic intentional weight loss that's not related to any health condition, just purely reducing the weight on the body.
Correct. Yes.
So if there is a provider that's listening to this, what should they do to get informed consent? I guess education to help their patients?
Well, yes. So doctors do need to understand that there absolutely are risks to taking these medications over the long term and the short term as well, much beyond nausea, vomiting, and like gallbladder issues, right? They go much beyond that. And to actually take the time to have these discussions with your patients. I mean, if I had my way, we wouldn't be prescribing this for intentional weight loss at all, to be fair, but I still respect this autonomy piece of patients being able to make the decision. But making that decision means considering all of these things and also really understanding why weight loss is so important to them in the first place, and then challenging some of those things because some of those things may not actually be true.
Yeah.
Yeah.
And from a patient perspective, where should we get information to make our own informed consent?
So this is where it's so challenging because so much money has been spent to make sure that we understand that this is what we need to do for this horrible obesity epidemic that apparently exists in North America. And so to try and find actual study data and to understand what that means is really difficult. And in fact, when people like me or other people who do research in this area try and talk about it, it's, we're either not listened to or we're criticized, quite deeply for shaming people who want to be on these medications. And that's not where this is coming from at all. As I've said, I support people if they're making an informed choice. It's just they're not informed. And so to answer your question, it's coming to people like you and me And, Reagan Chastain is she's on Substack. If you find her, she is excellent at very neutrally describing all of the studies that are happening in this area. And so there are places in, social media and online who are, providing this information. You just have to know where to look, because if you go to your doctor, I'm afraid to say you're probably not going to get the answers that you really need.
Yeah, because they probably are not looking beyond their own internalized fear of fatness. In prescribing medication, there's a principle that I remember studying, which was the decision standpoint was the risk versus the benefit. How much benefit we're going to get versus the risk. When prescribers have their own internalized fear of fatness, is the bias to determining that risk factor ratio, it is much more likely that people will be prescribed GLP-1 for excess weight than being guided to other resources.
100%. And so when physicians prescribe these medications, they truly believe they're helping patients, right? They believe if they lose weight, they're going to be healthier. They believe they're going to have less joint pain, right? And so they actually believe that they're helping the patient. But how many times have you been given a prescription for an antibiotic, for something, and were you actually given the risks and benefits before that? No, because people just, you don't question if you have a bacterial infection, you need an antibiotic. People don't question you're fat, you need a weight loss medication, right? It's unfortunate, but it's the way that it is.
Well, the risk-benefit ratio in taking an antibiotic, I remember last time I've taken it, I had diarrhea. But the benefit of the antibiotic was far greater than the 2 or 3 days of digestive issue.
Correct, right? But the point being, were you given the choice to make that decision?
No.
You just took the antibiotic.
Yeah.
Right? Yeah.
Which comes back to the same thing with the GLP-1.
Correct. It's just when we look at the balance, it falls on the side of harm for sure with these medications over the long term anyway.
One of the driving factor of many people deciding to take the medication is prevention for the fear of getting health condition like heart disease and diabetes. And when I meet people in coaching, right, not necessarily to decide, most people I work with have decided not to take the GLP-1 and they're doing the work to come at peace with their relationship to food or body. But one of the things that keeps creating a lot of anxiety with them in their decision process is the fear of getting sick and ultimately the fear of dying.
Of course.
Right?
Yeah.
The fear of death, we'll call it the fear of death for the intent and purpose of this conversation, is driving a lot of people to believe that their fatness is the cause of what potentially could be causing their deaths. And it comes back to that fear of dying. And I know that's partly what you do, right? You are an end-of-life provider.
I am. Yep.
What are your thoughts on that?
So I think this is such a fascinating question. And here's why. We're talking about two taboo subjects rolled into one, right? So we live in a culture where it's really not okay to talk about death, right? I mean, we push it aside. We don't talk about it. We don't even grieve publicly when someone close to us dies. And thinking about our own mortality and our own death is terrifying when it is such a taboo subject. And bodies are also a taboo subject. We will talk about standards that we're supposed to meet. At least we will implicitly by the messages we receive when we look, scroll through, Instagram and see all of these beautiful, filtered bodies, right? Or we'll even scroll through fat positive feeds. But we're not actually talking about what it means to live in a body, right? And I met someone recently who was writing a play called Bellies. And she was really struggling because it was so hard for people to even say the word belly, never mind sit down and watch a play about bellies, right? It's like there's so much shame that we carry about bodies and, our own body. And I don't care what size, shape, or color of body you live in, we all carry shame to some extent. And so if you combine that with this fear of death, it is an overwhelming, almost paralyzing place to be. And I think what ends up happening is it is so much easier to put all of that on weight, because in our brains we think weight is something I can do something about. I can take a medication, or I can go to the gym, or I can diet. I can at least do something and feel like I'm in control. When you're swimming in this sea of feeling like everything's out of control, you know what I mean?
Yeah, that's such an interesting perspective, because that's what it is about, is wanting to control, right?
Yes.
We're wanting to control that. We're wanting to control body because we're afraid. And when fear shows up, our kind of gut instinct is trying to get control.
Yeah, and here's the truth of it. Our bodies are not nearly as malleable as we think they are, right? It's like I can go spend 40 hours a week at the gym and I am still going to have short legs, right? Like I'm not, like there's parts of your body that you're just never going to change. And your body size and shape is part of that. We can only change that so much. And I don't think we should be. I think we should be embracing the body that we have. And that's a whole other discussion. But the other thing about this is what I have learned as an emergency physician in particular is that when it's your time, it's your time. I'm not even kidding. I will never forget a colleague talking about a patient who came after having a certain injury where he just hit his toe and he needed some stitches. And this colleague went back to write his chart a week later, and that guy had come back into the emergency department 2 days later after in that same spot something fell and hit his head and he died. And that story sticks with me because we just don't know when our end is. And, what makes me so angry, I'm full of rage, angry, is when people are, and women in particular, are living small and hiding in their own lives because they don't like the way they look, or they don't feel they deserve their goals, or whatever. They just have these self-imposed glass ceilings, knowing that life is so short and it can end, at any time. And it makes me so angry, and it breaks my heart to see women living small and hiding because of this relationship that they have with their body. It's devastating to me.
So when we think about the fear of death and its role in kind of skewing people on the medication like GLP-1, would part of the solution be approaching our own fear of death? I know for me, and I was telling you off recording session, that the reason why I'm able to approach this subject so fluently is because I've done my own work of thinking about my death and coming to peace with it spiritually. And that, I think it's part of the reason why I'm so comfortable in my body today. I'm not afraid of death.
Yes, I agree. And certainly being a medical assistance in dying provider has 100% changed how I view death and how I feel about death. And I have no fear of dying anymore either. And once I claimed that, once I decided I was no longer afraid of death, everything changed for me, including how I relate to my own body and my priorities in terms of the behaviors I want to engage in to support my health and what that means. And so I am no longer willing to restrict. I am no longer to engage in exercise that I hate or that makes me hurt. I lift weights with a trainer and I love it, but you know what I hate? I hate running. I'm not going to do it, right? But I come from like a decade of running marathons and hated every second of it because I thought it was going to, give me better cardiovascular health,
yeah.
right? And so to me, this is, what it's all about. I want to be healthy because I feel I want to be able to live fully each day, day to day. But what that means for me, how I define healthy, is so different than before, when I was afraid of my own mortality and afraid that my fat was going to be the thing that killed me.
Yeah, can we talk a little bit? Because very few people are wanting or able or willing to have this conversation. So both of us, if you're not seeing the video, both of us live in fat body, and both of us now realize that we've done our own piece with deaths. And when you say changed everything, it's changed everything, the context, particularly of your relationship to your body and how you behave around it. Is that what I'm hearing you say?
Absolutely. And so I came to this place of deciding that my body was my one true partner for the rest of my life, that I've got a great husband and I've got a great family, but that could change. I'm going to have my body until the day that I die, and I want to treat it well. And when I say treat it well, I mean respectfully. And so does that mean that I have cookies sometimes? Hell yeah, it sure does. Because sometimes cookies feeds my heart and my spirit in beautiful ways, right? But I also eat vegetables, right? And it's understanding that I feel better when I move my body. But also there's some days where my body's saying, Michelle, you're exhausted, rest. And then I honor that as well, right? And so some of the things that have changed is I've cut my working hours in half. I don't burn the candles at both ends anymore. I carve out time to spend time in nature, to actually prepare food at home rather than just relying on takeout all the time. And I just feel better having a slightly slower pace of life. And, that's what this all means to me. And I don't care about my weight. It's like, I truly don't. And it took me a long time to get to this point. And, I won't lie, sometimes I'll be shopping and I'll look at an outfit and I'll wish I had a body that could fit into this outfit. Or, sometimes I was just on a plane home from a conference a few days ago, right? And people look at me and think, oh, I hope I don't have to, sit next to her. And so I have moments where I wish things were different, but I no longer want to change my body to feel like I deserve any of those things. I can go find an outfit that feels great and looks amazing. Might not just be that exact one, right? And I deserve to fly to a conference just like anybody else does, etc.
What I hear you say is I'm no longer willing to suffer in order to be smaller so that I can perhaps delay death. Like you want to live well right now.
Well, correct. And just incidentally, if we want to bring this back, there's science to support this.
Is there?
Right? There is science to support this. And so there are some amazing studies done. There's one landmark studies done, just about a decade ago, maybe more, where they looked at 4 different health related behaviors. And I don't remember them specifically, but one had to do with alcohol, one had to do with movement, one had to do with vegetable intake, and I think smoking might have been the 4th. I can't remember the precise details of the habits, but they looked at risk of mortality versus weight. And if you are engaging in these 4 behaviors, the risk of death is the same regardless of how much you weigh. And there's also many studies that show cardiovascular fitness in particular is a much better predictor of mortality or death than weight is as well. So somebody who lives in a bigger body but gets movement in has a lower chance of death than a person in a smaller body who doesn't move at all. And I know that there are challenges to movement when you're in a bigger body that, we feel ostracized or unsafe in big box gyms. We might have mobility issues, but there are ways, right? And sometimes it's a matter of tuning out the voices that say, you must get 150 minutes of cardio and, an hour of weight training every week. And, you have to put those guidelines out and look like, what can I afford? What will my body let me do? What will I enjoy? And taking that approach will actually result in more benefit than sitting here trying to intentionally lose weight in ways that are making you miserable. Because, we could do a whole other episode on what happens in your brain when you start restricting food and forcing movement and other things. It all tends to backfire on us. And so focusing on the things that make you feel good, that's what actually contributes to your health way more than intentional weight loss ever does.
We're wrapping up the episodes, but I want to come back to the informed consent. I know of a tool, and I'm not sure if you heard about it, because I want to make sure people listening to this podcast have it. It's the Association of Students of Weight Inclusive Care. I can't remember. It's a group of students who did an informed consent documents on GLP-1. Have you heard about this?
I absolutely have, and it's an amazing document. I highly recommend everybody check that out for sure.
Okay, so we're going to link it in the show notes. So people listening to this who do not have resources or skills to read research, this part of this work anyway has been done for you in a more lay terms language. So I'll put that in the show notes.
Perfect.
People listening to this podcast, where can they find you, Dr. Michelle?
Well, thank you. I am on Instagram at Wayza Health. It's WAYZA Health. That is the best place to find me. You can also find me on my website, which is also wayzahealth.com. Lots of resources there, including a blog, my own podcast, Thrive Beyond Size, and information on my brand new membership that's opening on May 11th.
What is that membership about?
It is called Enough Already. And what I have learned over my years of working with women is that when we want to start doing this work of approaching our body and our health based on what it's asking for and what it needs, rather than what other people are telling us we should need, is we have to feel safe enough and comfortable enough to stay in our bodies to begin to understand the language that it uses to communicate with us. And so this membership will be giving people tools to come back home to their own bodies so they can feel safe again. So I'm also a yoga teacher, and so we'll be doing some gentle yoga practices and some meditation and some nervous system and somatic work to let people feel comfortable in their bodies again. And then we can move on to the work of actually healing our relationship with food and body.
Is that the new direction for Dr. Michelle from emergency care? Because that's quite the departure between the two worlds.
I still work as an emergency physician. I still also do the medical assistance in dying. I actually support physicians in mental health and burnout as well. But yes, my goal is eventually to do less emergency medicine. Yeah. Why, you might ask? Because shift work is no longer great for my body. The environment is, I'm in perimenopause and dealing with all the things, and the lifestyle that comes along with it just doesn't fit with what I need anymore. So hopefully soon.
I think this is the perfect example of the life choices that change once you accept your body. You face that peace with that. You start realigning stuff in your life so you can live it fully now.
Well, and let me just be honest. I mean, it feels so amazing on this side of it. Hardest thing I've ever done. right? It's not easy to say no and to put some of the responsibilities away, and to prioritize yourself in such a meaningful and profound way. It was the hardest thing I've ever done, but am I ever grateful that I took that journey.
I hear you. I was there 14 years ago. I made that choice. I
Good
just
for
posted
you.
this morning on Facebook about that. There was a memory that came up on Facebook of that part of my life where I took a complete leap of faith and was like lived in fear for like 2 years. But it's the greatest
Yeah.
thing I've done. So
Yeah.
you're courageous, and the end of the tunnel is going to be beautiful.
Yes, it is. Yes, it is. I can see it clear as day. Yeah.
Yeah. Thank you, Michelle, for having been with us today.
Thank you. This was great fun.
Want to coach behaviors, not bodies? Learn the mindset tool and the method that create real changes? Join the waitlist for the next cohort of the non-diet coaching certification at stephaniedodie.com/waitlist. That's where the real training begins. And I'll see you on the other side, my sisters.